Hello, everyone, and welcome to the Down Syndrome Center of Western Pennsylvania podcast. As always, I am your host, Dr. Kishore Velody, and as you can see, we are doing a video podcast, which is something that we don't do very often, but for today's topic, I felt like it was really important to do because today we're going to be talking about skin or dermatologic conditions in people with Down syndrome, and I am so excited to have Dr. Jillian Rork on this podcast with me today. I'll have Dr. Rork introduce herself here in a second, but I met her at the Down Syndrome Medical Interest Group meeting, which is our big national meeting where all of us who work in Down syndrome centers come together and learn from the experts. And Dr. Rork was our dermatology expert a few years ago. And I said, oh, we need to do a podcast on that. And here we are. So Dr. Rork, thank you so much for joining us.
Oh my goodness, it's my pleasure. I'm so excited to be here and talk about my favorite topic, dermatology and Down syndrome.
I love it. Now, maybe you could give us a little bit of an intro, like who are you, where are you working at, and where are you from, and why is it that this topic is so exciting to you?
Yeah, sure thing. So I am in New Hampshire. I work at Dartmouth Hitchcock Medical Center. I've been committed to the Down syndrome community, I think, for a long time, as has my family. I think my interest was first started back, learning about what my grandmother did, which was work with Down syndrome individuals in public schools. And then my mother worked at Easter Seals for many, many years as a pediatric physical therapist, and I got to know a lot of people in the Down syndrome community there. But, I think my interest really started in medical school, meeting some wonderful doctors and other providers committed to the Down syndrome community, and then just starting to notice that as they came to the dermatology clinic, that they had a lot of issues with their skin. And this was not really talked about, certainly in the literature. And I just really felt like that needed to be explored more, and just really kind of fell in love with a lot of those topics of skin conditions that they have, and also the community themselves. So yeah, I'm really excited to be here, excited to be part of the Down syndrome community. So.
Well, we are excited to have you with us today as well. So you actually have put together several pictures to kind of go through some of the topics we're going to be talking about in this podcast. I think given the number of topics we're going to discuss, we might even do this in 2 or 3 separate podcasts if that works out for you.
Oh, no, that sounds great.
Awesome. Well, tell us if you want just a little bit about where you got the pictures from and what we're going to be looking at in general, and then we'll get right into it.
Yeah, sure. So, I want people to feel kind of liberated to listen to this too, and not just have to look at the photographs. But most of these photographs are pictures of my patients, and their extreme generosity letting me share them with all of you. There are some photographs kind of intermingled in here that may not be patients with Down syndrome, because I really wanted to highlight classic kind of features of a lot of these skin conditions. And I just did not have good enough quality slides to show you. So we'll also talk about how different skin conditions look like in different skin types, which I think is really important. And so we'll kind of walk through the slides, but we'll also do our best to kind of make this interactive for those of you listening while you're walking or driving in the car.
Fantastic. Well, why don't we go ahead and just get started? Let me tell you, the first patient we'll be talking about is one that I see very frequently, a 6-year-old, let's say 6-year-old boy with a dry, flaky skin. I'll pull up his picture here in just a second. You can see there's some really dry skin, thicker maybe at the elbows and the knees and the feet. So what would you think as you see these pictures as I show you them?
Yeah, sure. So I would think, this is probably one of the most common problems that we end up talking about in the dermatology clinic with patient with Down syndrome, and that is dry skin. In particular, I tend to find in patients that their skin is most dry on their hands and their feet, but also they tend to get thicker dry skin on their elbows, on their knees, as we see in some of these photographs, and also sometimes on the bottom of the feet. So, I'd love to kind of talk about my approach on how to treat dry skin and give you some tips on that, since it's
Please
such
do,
a common
because I know
problem.
that's something that we deal with so much.
Yeah. So, I think one of the most important things to understand with dry skin and treatment of dry skin is that there are different strengths of moisturizers. And I break it down into three basic categories to try to help you manage when you go to the drugstore and try to find something to put on your skin that's going to help. It is so overwhelming. So the first category of moisturizers that I'll go through are lotions, okay? And those are typically actually the weakest moisturizers that we have. Lotions typically come in pump bottles, so that's a really good way to remember it. They have the highest water and alcohol content of the moisturizers. And it's kind of for that reason that they're kind of not the strongest moisturizers that we have. They also can sometimes sting or burn, which we never want that to happen when we're trying to help somebody with their skin problem. So in general, I'm a pediatric dermatologist, so I really don't want things to ever hurt for kids, obviously for adults too, but in particular with kids. So I in general tell people if you're bringing up dry skin to a doctor, you should probably just steer clear of lotions. So the second strength of moisturizers and what we call kind of the medium strength are creams. And those tend to come in jars. They typically are a bit thicker than lotions, which is why it's hard to find them in a pump bottle because we just can't pump them through them. Mm-hmm. And those are kind of that happy medium. And a lot of patients really do like creams because they're not quite as sticky as some of the stronger moisturizers, but they definitely moisturize better than a lotion. So then the third category of moisturizers are ointments. And when we think of an ointment, we think of petroleum jelly. And then also in that category would be oils. And so those are certainly the strongest moisturizers that we have. They really never hurt, but they're pretty sticky. So kind of with that rubric of lotions, creams, and ointments, it's important to kind of see how severe is the dry skin. Is this something that we think, might be able to be managed by a cream? And geez, if it's not working too well, maybe we can step it up and use some ointment on some of those hot spots. So that's, I think, hopefully helpful for people to kind of figure out what products to use. There's also a lot to timing of moisturizer and really kind of getting the most bang per buck of taking time to put moisturizer on the skin. I do tend to find that applying it right after you get out of the bath or the shower is typically the most helpful. You want to dry the skin off a little bit, but leave some moisture on there so that when you put on the moisturizer, you're kind of sealing in that moisture and really helping to hydrate the skin. So yeah.
That's fantastic. Oh my gosh. I feel like before I started this clinic, I should have taken stock in Petroleum Jelly Company. That name would have been a good stock for me because I talk about that all the time.
Absolutely is a fabulous moisturizer. It is cheap and easily available, and it just works wonderfully. And, I talk a lot about with families kind of that's the sensory issue with putting on a moisturizer, because I hear that a lot. It's like, my kid just doesn't like the way that feels. And I get that. And that's why sometimes it is nice to use a cream. It's also really nice to engage the person in putting it on. We talk a lot about body painting and even with little kids, spelling things or drawing hearts on their back with your moisturizer and then rubbing it in or letting the kid rub it in or talking about it that it's their superhero power lotion and just trying to make it engage. Yeah, keeping it fun. And honestly, with Down syndrome, because we kind of know that dry skin is probably going to be an issue from infancy through adulthood, working it into the routine really early on in life. I think that that's really helpful. And it's a point of empowerment for a lot of patients. So getting started young, I think, is really helpful too.
Well, I think that that's going to be great advice for a lot of the topics they're going to be talking about today. Let me give you another one. This is a 10-year-old boy who has tiny pink scaly bumps on his face, arms, and legs that look like this.
So this is called Keratosis pilaris, or a lot of the time we call it KP, or I have patients and families call it my bumpy chicken skin. And this is a very common form of dry skin that we see in the general population, but we also see in Down syndrome. When you are younger, it tends to be a bit more present on the face, and it tends to happen kind of on the sides of the cheeks, kind of approaching the hairline. And oftentimes there's kind of an underlying reddish appearance to the skin. Typically with time, it gets better on the face, and it will kind of migrate and stay on the backs of the arms and the legs. I think one really good tip for moisturizing or kind of helping with this kind of dry skin is using a moisturizer that has something called a keratolytic in it, which means that it has a little bit of an exfoliator in it. And so sometimes that can be a moisturizer that has salicylic acid or amlactin in it. And sometimes those moisturizers can be a little harsh and can be a little stingy. So if people do want to start using them, I say, maybe once or twice a week to start out. But it can help kind of loosen up those white bumps within this form of dry skin and give the skin a smoother texture. I have to be honest, though, a lot of people aren't bothered by this. A lot of people don't know that they have it. And so I kind of say, hey, if it's not bothering you, it's not really bothering me. We don't want to go ahead and treat things that aren't bothering somebody. But if it is, because sometimes it does, it gets itchy or, cosmetically, it's you want to have some improvement to it. I think using a moisturizer with a keratolytic is very helpful.
Awesome. All right. Well, let me give you another one. This is going to be, our next one will be a 15-year-old with a pink, scaly, itchy area on her neck. And we'll look at another picture here in just a second of another patient with maybe a little bit of a darker skin tone that we can see what this looks like. Do you want me to show that now?
Yeah. Oh, actually, sure. Let's do that. That sounds
all right. There
we'll
we
just
go.
show both of them. Yeah.
Okay.
So these are two different slides of eczema, which is another thing that we really frequently see in the dermatology clinic. And I think it is because there's such a high rate of sensitive skin and dry skin that it's not uncommon that we can kind of tip into the eczema category. I chose two sets of slides because I think it's important that eczema, you need to know that eczema looks different depending on skin type. So in a fair skin type, it typically is more pink. It tends to be kind of clustered together in what we would call a plaque or just one single area. And you may have lots of plaques all over the body, but it tends to kind of stay pretty tight. Whereas there's obviously exceptions to every case, but in darker skin tones, sometimes we see something called follicular prominent eczema, which just means that the bumps are going to be a little bit more diffuse. And rather than having a pink color, you might see a more skin toned bump or a brown bump. And I bring this up because a lot of the times I have patients come in to me who have darker skin tones, and there's a question like, nobody knew what this rash was, and it very oftentimes is eczema. So I think that's a really good pearl to remember when we're looking at eczema. So, in terms of treatment of eczema, a lot of the times going back to that knowledge of different strengths of moisturizers is very helpful. So this would be, a patch of eczema would be something that I might advocate doing an ointment on because that is going to be the most hydrating. We oftentimes do use topical steroids, and there's all different strengths of topical steroids that can help with this. But I'm going to go back to that pearl that we never want anything to hurt that we put on the skin. And so oftentimes I never prescribe topical steroid creams. I almost always prescribe ointments. Unless, again, it's that whole texture question where people don't want something sticky on their skin. Ointments do not hurt and they penetrate the skin better. So that might be a nice thing to ask, your provider. If your child has Down syndrome and has eczema, you might want to ask them, hey, maybe can we try an ointment? Because I heard that might work a bit better, and it might avoid kind of that unnecessary side effect of something hurting while trying to improve it.
So for the eczema, then it's going to be the steroids, if needed. Otherwise, moisturization, is that sometimes enough to do it, or do you always feel like steroids are needed when it gets to this?
Yeah, absolutely. I mean, there's a huge spectrum of eczema, and so in some cases, it is actually just upping that strength of moisturizer. But I usually say to parents as we're learning and navigating eczema, if you try to bump up the moisturizer for 2 to 3 days and you're not noticing a difference, then it is probably helpful to start using a topical steroid. And like I said, topical steroids come in all different strengths, and the majority of eczema we're able to use weaker topical steroids and use them in a fashion where you don't need to rely on them. You use them when the skin is flaring, but then you really rely heavily on your moisturizers when you don't need it.
Great. All right. Well, let me give you another one then. This one will go into the adult range. We have a 30-year-old woman who has these faint purple red appearing spots, almost like a fishnet, and this is on her legs.
Yeah, so this is a really common question that I get in clinic too. So the fancy word for the skin condition is called cutis marmorata, and we notice it mostly in babies.
Yeah,
but in Down syndrome, it certainly can kind of travel through the lifespan. And basically what it is, it's very superficial blood vessels, superficial vasculature that is kind of dilating and contracting all at the same time, usually in response to cold. Mm-hmm. And it is absolutely not harmful. It is not a sign of another condition. So sometimes this can be a sign of different autoimmune conditions, but in the Down syndrome community, it is what we would call a benign finding, which means it's something that we know about, but it's not at all harmful.
And often for me, I find when the babies come in, especially if they haven't had their cardiac repair, a lot of the times the families will see this and wonder if it could be the heart. And I do a lot of reassurance that it's not. It's a different color when you have a heart issue. Yeah, absolutely.
No, that's a really good point.
Yeah. Great. Okay. Well, that was a good and easy one. So what is the treatment? Just rewarming then?
Rewarming and reassurance.
Okay.
Yes. Yep.
Very good. All right. Well, let me give another one then. Let's talk about a 16-year-old boy who has this chapped lips and sores on the corners of his mouth. What would you call this? How would you treat this?
Sure. So I would call this dry lips, or chelitis is the fancy dermatology word for it. But I think the really important thing is knowing this diagnosis at the corners of the mouth. That is called angular chelitis. And this is something that we come across pretty frequently. And I think it has to do with the fact that oral motor tone is sometimes lower in individuals with Down syndrome. And also the tongue tends to be larger. And so it is harder to control oral secretions kind of piling in the corners of the mouth. And so oftentimes what happens is we kind of get that saliva caught in the corners of the mouth, and then oftentimes yeast and even sometimes bacteria can kind of grow in that area, and it can cause these little sores at the corners of the mouth. it's really uncomfortable. And so a simple treatment for this is using an antifungal cream, and there are several that are available quite easily over the counter. My favorite one is clotrimazole 1% cream. Mm-hmm. And oftentimes applying this 2 to 3 times a day to the corners of the mouth. Again, we're going to mention it, Dr. Volodi, with a little bit of Vaseline over the top and on the lips can be really helpful. Sometimes that's not enough. And then I think it is the time to bring it to the attention of your provider, because I will sometimes prescribe a topical steroid ointment, a weaker one to kind of mix in with that clotrimazole, and that can be helpful. You want to be careful continuously applying topical steroids to the face, because sometimes, there's side effects with that. It can thin the skin, sometimes breed more yeast and bacteria overgrowth, but sometimes those are helpful. So
that's great. So for this same boy, you see this child in the clinic, and he opens his mouth and we see this on the tongue. And I know that sometimes families can be surprised if they haven't seen their child's tongue, or the teacher might say, "What's wrong?" So what is this?
Yes. So this is normal. This is something called lingua plicata, or fissured tongue. And it is nothing to be concerned about. This is actually very well described in patients with Down syndrome, and other people who don't have Down syndrome can have this. And so it's not a sign of an underlying illness or anything to be concerned of.
Awesome. So this is not any type of infection or
nope. Yeah. And so sometimes I have the question, hey, is this a sign that that he or she could develop psoriasis? And that's a different condition on the tongue. It's something called geographic tongue. It looks different than this. And so I've gotten that question a couple of times. So I just want to bring that to people's attention. It is not a sign that you're going to develop psoriasis.
Awesome. Well, let's do a couple more. And I do think, looking at the time, we're probably going to have to do this over 2 podcasts because we don't want to have such a large a podcast file that people's phones can't download it.
We do not want that. Happy to come back and talk more.
I appreciate that. Okay, well, let's look at this one first. Let's say this is a 20-year-old who comes in with these kind of red bumps around the mouth. And question is, what do we do? What is this, and what do we do to treat it?
Sure. So this is something called perioral dermatitis. Let me tell you, this is a hot thing to have these days with mask wearing. So you might see this on the rise. I had clinic yesterday. I think I had 4 people I diagnosed with it. So perioral dermatitis, though, certainly existed pre-mask wearing COVID days. It's a common thing that we see both in children and adults. We don't know exactly what causes it. Oftentimes there is a history of either inhaled corticosteroids, which is, something that a lot of our patients are using, and or use of topical steroids around the mouth, that this problem can happen. I also do tend to find that saliva, and again, going back to that oral motor control and secretions, can definitely trigger off perioral dermatitis. So there's a couple of pearls with this. Sometimes when people see rashes around the mouth, the automatic thought is, I'm going to put some topical steroid on that. I bet it'll get better. And unfortunately, that is not the right move with perioral dermatitis, because it might get a little bit better, but then it's going to get worse. And so I tell people, how do you identify perioral dermatitis so you don't make that mistake? Look for the rash not only around the mouth in these teeny tiny little bumps, usually they're not very scaly, but also look for some clues around the nose, and it can also happen around the eyes. And so if you have a rash, pink rash, kind of going up around the nose and around the eyes, you're oftentimes dealing with perioral dermatitis. The treatment of this kind of varies in terms of how severe it is. Oftentimes using a topical antibiotic like clindamycin 1% lotion, or metronidazole cream, or even sometimes some other anti-inflammatory prescription creams like tacrolimus can be really helpful. A lot of the times when people come in and they have this and they were given the right treatment by their provider beforehand, but it's not working, it's because they're not putting it on for long enough. A lot of the times if you use those treatments that are given to you for 2 weeks, the rash gets better and you're like, yes, I'm done with this. But there's a really nice pearl that oftentimes you have to treat normal looking skin where you had perioral dermatitis for 2 weeks after it's gone away. And if you don't do that, sometimes it can come back. So that's a nice pearl. If you're ever given those treatments, just know that typically you need to apply it for about 4 to 6 weeks. And if it goes away quickly in 2 weeks or so, you should probably add on a couple more weeks of treating the skin just to make sure it doesn't come back.
All right, interesting. Okay. Well, then let's look at one more, and this will take us back into our pediatric age range. It's a 6-month-old who has red areas in the diaper that look like this. So what is this and how would you manage this?
Yes, yeah. So, diaper rash, diaper rash can be tricky. I chose this slide because this is a really nice picture of something called irritant diaper rash, which means that it's probably from stool and from urine, and there's no sign of any infection here. And I think that that's what I see most often in babies, children, and adults with Down syndrome. So I just wanted to give some tips in terms of how to take care of that area. So we really tend to over wipe. So in a baby, a lot of the times, especially for using these amazing disposable diapers that just take so much moisture off the skin, we really only need to be wiping after a stool and not really wiping as much with just a wet diaper. You can certainly pat the area dry, but you don't necessarily need to use a disposable wipe. Because a lot of those wipes, no matter how good or fragrance-free they are, they have a lot of stuff in them. And so minimizing wiping can be very helpful. We also want to use really simple barriers. And again, my favorite in the diaper area is petroleum jelly. Sometimes using the kind of more commercial brand name diaper ointments, they also have a lot of compounds in them. If you are going to use a zinc oxide, which is oftentimes recommended for a more irritating diaper rash like this, there is generic 20% zinc oxide that works great, and you can get that at the drugstore. Know that you do not need to wipe off all of the zinc oxide between every change. Sometimes I feel like there's that need to get all that white stuff off, and I say, no, unless it's a stool, unless it's a bowel movement, you can leave that on. Sometimes when diaper rash is this irritating, using a soft washcloth or a soft paper towel that's just soaked with a little bit of lukewarm water or mineral oil, or again, Vaseline to wipe the area is actually far less irritating. I have a lot of questions about diapers, like what brand, and I changed, 5 diapers and my kid's rash is still the same. I would say for the vast majority, you don't actually need to change your brand of diaper. It usually has to do more with getting a good barrier ointment on and not over wiping. Now, you can try all those tricks, and sometimes it's just not going to do it. And that's when you do need to talk to your provider, because adding in a topical steroid and oftentimes a topical antifungal mixed in can be the way to help irritant diaper rash.
That's great. Wow. All right. We will look at now this young person who is 9 years old and has developed these smooth bald spots on the head. So what is this and what do we do about it?
Yes. So this is something called alopecia areata. This is a common form of hair loss that we see in Down syndrome. It is considered an autoimmune form of hair loss. As a lot of us know, autoimmune conditions are more common in individuals with Down syndrome. And we think it's, kind of for this reason that we see more alopecia areata.
Huh. What can we do once we see it developing? What can be used to treat it? Anything?
Sure. So there are actually some good treatments for alopecia areata. I have to say that it is challenging, but that is not to say that we should just say, oh, there's nothing to do about it, because that's not the right answer at all. Oftentimes, I like to go through all the various treatment options with the patient and family and figure out what's a good fit. So first line for treatments are topical steroids. And oftentimes we will use more of a medium strength topical steroid. It's really good for people to know that topical steroids come in solutions, which means that they come in a liquid form. Sometimes I'll have people referred in and they've been told to put creams and ointments on their head, and man, that gets pretty messy and that's really hard to put on. So please know that there are liquids and there are even oil topical steroids that can be helpful. So this oftentimes, though, is a condition that if your child or loved one has, it is nice to see a dermatologist for this, so that they can help navigate through that right strength of steroids. We can sometimes do injection steroids into the spot, but I'm very open and honest that that is sometimes quite uncomfortable. There are different over-the-counter medications that we can sometimes use. One that's called Rogaine that people might have heard of, or also minoxidil. Sometimes we do use certain treatments by mouth for this. There are some newer medications kind of on the horizon, something called JAK inhibitors that can potentially be very helpful for this. We're trying to explore cream versions of those JAK inhibitors to see if those could potentially be helpful. So there's actually a lot of excitement and momentum right now in the alopecia areata community in terms of treatments. So I think that there's a lot to be seen on the horizon.
That's fantastic. Yeah.
I do want to mention one very important thing with alopecia areata is that there is sometimes a tie between alopecia areata and low thyroid, or something called hypothyroidism. And we know that low thyroid is more common in individuals with Down syndrome. And so it is very important that if your child has alopecia areata, that they are up to date on their thyroid screening, because that could potentially be a sign that they either have an underlying thyroid condition or they may develop it. So we want to make sure that we're really following those American Academy of Pediatrics, health supervision guidelines for, frequent annual TSH screening, especially if you have alopecia areata.
Awesome. Thanks for that advice. Yeah, that's great. I do think, Jillian, if you are okay with it, why don't we do this? We've covered a lot of great information. I think that our listeners will have a lot to digest on some really common things that we see in our population. Would you be okay with coming back and doing another podcast with us here in a little bit?
Oh, of course. It'd be my pleasure. Thanks for inviting me to talk.
Oh my gosh, of course. And thanks for being willing to come back too. And to our listeners, I hope you found this as interesting as I have. And what we're going to do, we will schedule a time for Dr. Rork and I to get back together again. We'll do, I think she's got a few more cases that she would love to talk with us about and educate us about in terms of skincare in people with Down syndrome. But until next time, if there are other topics that you would like to hear about, by all means, reach out to us at Down Syndrome Center at chp.edu. Just drop us a line. Let us know how you like the podcast or if there's anything you want us to cover. But until next time.